I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's guest is somewhat special. He's 12-hour time difference from where we are here in Pittsburgh, where I'm actually recording this. We have someone who has had a lot of experience in healthcare outside the United States, which I think is a very interesting story to tell. And it's very educational, I think, for folks here in the United States to see what happens in other parts of the world. So without much ado, I'm going to introduce Dr. Alwi as a senior consultant cardiac surgeon at the National Heart Institute in Kuala Lumpur, Malaysia. His primary clinical interests lie in adult cardiac surgery, where he brings extensive expertise managing complex cardiac cases and performing advanced surgical procedures. But that's not the reason he's on the podcast today. Beyond the operating room, Dr. Alwi is passionate about advocating the transformative potential of digital technologies in healthcare. He serves as in a dual role as clinical director of health informatics at IJN, where he also plays a pivotal role in driving the Institute's digital transformation agenda, which has been extensive, bridging the gap between clinical excellence and the cutting-edge technology in healthcare. His special interest lies in the application of artificial intelligence, particularly in the development of software as a medical device solutions within the healthcare setting. Dr. Alwi is actively engaged in advancing AI-driven tools, support clinical decision-making, enhance patient safety, and enabling precision medicine. And through his leadership, he has taken IJN from basically the paper world to about as far as you can go in the electronic healthcare world. Welcome to the podcast, Dr. Alwi.
Thanks, Jay. Pleasure to be here.
So to start out, you're a cardiac surgeon. I'm an internist, but we didn't start out in healthcare IT. So tell us a little bit about how you got interested in being a clinical informatics person and getting into healthcare technology.
I'm at a generation in which we were at the cusp of computers. When I first entered university, we transformed the way we registered students from a paper-based registration to a computer-based registration. And that made the process so much faster that we were the only center that got our work done before lunch. Everybody else was way towards the evening. So I've got a long history with this, but it was more just an interest. When I joined the National Heart Institute, I was put in charge of our risk stratification program. That's a method in which patients come in for surgery, and based on their preoperative risk profile, we assign them a risk that they will have for surgery. And that allowed us to see which patients needed more care, which needed more attention, and helped us with improving outcomes. So I've always been interested in this, and I joined the National Heart Institute in 1996. In 1998, we went to South Korea to evaluate our hospital information system. I remember that very well because all the screensavers had Titanic on them, Leonardo DiCaprio and Kate Winslet. So that was the way it was. But what the eye-opener there was, even then, computers were not very apparent in our own hospital, but was everywhere in South Korea. I then did a year's fellowship at the Mayo Clinic in Rochester, Minnesota. And again, I was then exposed to how even 20 years ago, critical care information systems were very much in play at the Mayo Clinic. They were very much paper-based, but they were already making that transition. So we wanted over the years to have the same done at the National Heart Institute here. A lot of our doctors are actually American trained. So it's something that we wanted to do, but we had a lot of failed starts until last year. In which we decided that it was not so much a vendor that we needed to select, but we needed to empower our people to decide what they wanted for their own area of work and give them the digital tools in which to get that. And as a hospital, as an organization, coordinate those efforts across the organization. So we were quite fortunate in that regard to get that done.
You undertook basically a project going from paper to almost 95% everything electronic. And
Correct.
and explain to the listeners what the EMRAM system means and how that's important to IJN.
Okay. The MLAN system is a methodology, and it allows us to be able to identify how the organization as a whole needs to prepare itself for digitalization. So the thing about IJN is IJN is a JCI accredited hospital. For your listeners, you're probably the American equivalent to this is the, let me try and remember that.
Probably JCHO.
JCHO, exactly. So hospitals in the US have to comply with JCHO in order to get Medicare funding. If
Correct.
not, you're dropped from Medicare funding. So you have to comply to what JCHO puts out as your requirements, and they're very clear with it. The good thing about American organizations is you have your requirement, you have your measurable element, and therefore that allows you to do a gap analysis of where you are and where you need to be. So we've been JCI accredited for many decades. So when we approach MRAM, it's very familiar. Again, there's a standard, there's a measurable element, and there's a gap analysis. So that's the process that we took in our own hospital, that we divided the work across the organization to each area, for example, physiotherapy, nursing, cardiology, cardiac surgery. You assessed your area, you looked at what your requirements were, you did a gap analysis, and we guided them as to how long you needed, what you needed in order to close that gap. And these were assigned a clinical lead, administrative lead, and an IT lead. So we broke up the task. Now, this it's not that we came to this from zero per se, meaning that we were very much a paper-based hospital, but we did have a PACS system. We did have a hospital information system, but we did not have a documentation engine within the hospital information system. That we had to build. And well, and the documentation system that we had to build also needed, because of MVAM, to comply with standards like SNOMED, ICD, Medicomp. So all of these things needed to comply as well, and we could not write that. So we had to buy that bit and augment the documentation engine with that. But the key to all of this was still that it was developed within the hospital. We have an IT department that had, before we started this, maybe 20 programmers and systems analysts. Now we've tripled that. So it's largely a system that's built in-house.
So interestingly, I've also had some interest or some experience in implementing these systems. It's not an easy task to
No,
go
it's not.
about getting requirements together and getting staff
Yeah,
together and getting all the things you need to put something like this into place. So
yeah.
could you talk about some of the challenges that you had and how you to prioritize those?
Yes, that's where MVAM comes in. In terms of MVAM provided us with the structure and the priority, meaning that we wanted to be, when we first did our MVAM evaluation, we were at stage 0. Well, we argued that we were actually at stage 1, but they said no. Although you got 72 at stage 1, we are grading you as 0. So we were at 0. Then we looked at what is required for stage 6 across, and did our gap analysis, and did our toolkit on what you needed to do to get your particular area of work out of that and into 6. But that allowed us to prioritize tasks, meaning everybody wants their own area to get up to speed faster, and most have an idea of what they want. But having the MRAM methodology enables us to say, no, we're going to 6 in November. What you want is not in our task list, and we'll do that after. So that does allow us prioritization, and it also gives a target, because people don't work so well unless they have a goalpost. So that helped us quite a bit.
So I'm going to back up just a little bit for our listeners and give them a definition of what EMRAM actually is. It was developed by HIMSS, and it is a structure, and it
Yes.
has different stages. Well, 0 through 7.
Yeah.
And it's called Electronic Medical Record Adoption Model. That's what EMRAM actually stands for. So we're talking about EMRAM. I just want to make sure everybody understood exactly what we're
Right.
talking about here.
Yeah.
It's not so much done here in the United States, but it's done all over other parts of the world. So
Yeah.
it's a little different. So I wanted folks to understand what we're talking about here. So you got your requirements. You've got your steps to go through the MRAM. You wanted to go to stage 6. How did you go through the process choosing vendors? And to be full disclosure here, this podcast is sponsored by Medicomp Systems that produces Quippe, which is one of the products that you chose. So talk a little bit about how you evaluated
Sure.
that
Now,
product.
the thing about this is when we wanted to go through this journey, what we normally do in this regard is find somebody that will help us go through it, that will allow us to navigate this process an easy way. Yeah. So what we did was we looked at which hospitals had already implemented an MRAM strategy, and in Malaysia there were none. So we looked to our neighbors, and in Thailand there are many. There were not that many in Singapore either. Indonesia some, but Thailand many. So we did a trip to Thailand to MRAM accredited hospitals, and we toured them, and in order to decide whether or not this was a journey that we could undertake in the time frame that we had set for ourselves. In this, we were fortuitous enough to meet Miss Piano Nyenjit of APUK Medical Services, who is in the digital transformation line of work as well. And we engaged her to be our consultant. So our vendor selection, because we had to close this gap in a very short period of time. It was under a year. Our normal acquisition processes usually take about 1 year. So we could not go through the normal processes in order to vendor select for our data engine. So we selected Medicomp on Apuk's recommendation.
Okay.
So that's how that went. And we had to go to our board saying we are not going through the usual processes, and not because of any discrepancy in our choosing of our choosing, but
Mhm.
because of the time frame, and thankfully our board agreed. This I think it's good though. I have no regrets on this. The continued work that has been done between APUK, Medicomp, and IJN has been tremendous, and we've been very pleased with the response from our partners in this. We regard them as partners. We don't regard them as vendors in getting the work done, because there's a lot of work to be done. We are going for our JCI accreditation in November again. So we are closing a lot of gaps with our documentation. As you well imagine, our EMR turns exactly one today. 10/10/24 was when we went live last year. And 10/10/25 is today, this afternoon we celebrate our EMR turning one. We've got a barbecue planned in the hospital as well.
So you talk about joint commission. I'm just going to use that as a phrase: Joint Commission International, Joint Commission JCHO we have here in the United States. You mentioned how important those things are together with your implementation of your documentation. Can you talk a little bit about, once you've implemented this system, how that has helped with your accreditation process?
Well, we have always had a problem with our accreditation process on a paper record with legibility, with time, date stamps, with completeness of the record, and the ability to assess this. That all goes away immediately with an electronic record. So it does help us in that sense. Yeah. My quality guys, though, the one that are preparing for our upcoming JCI accreditation, however, for each of our GAP meetings going on, the EMR group is under tremendous pressure to make sure that we don't expose ourselves to any dangers of not being accredited now that we feel that it's something that we it's a journey that we have to go through. It's not something that we can avoid for much longer, because a paper medical record is an inability to mobilize data. An electronic medical record gives us the ability to move that data to where it needs to be seen. Not only by clinicians, but also we have a patient app that pushes patient data, their medical records, their operation notes, their lab results, their prescriptions, all of that. And in a world in which we did not have that to a world in which we do have that, I think it's a huge difference. I don't know how it is in the United States, but I think patients will increasingly demand that they have access to that data in real time.
Well, there's a huge push in the United States for direct patient access to clinical data. And I think, to be honest, I think some parts of the world are ahead of us in that regard. They've actually gone faster than what the US has gone. The clinical workflows, though, however, in Southeast Asia and Malaysia are they are somewhat different than they are here in the United States.
Yeah, I
Because
would agree.
when we talk about clinical medicine here, primarily when we document medical records for whatever reason, it's primarily to submit a bill. That's what we do here in the United States.
Yeah,
However, what I've observed in Southeast Asia is how it's all about the patient care. How
yeah.
can I advance it? How can I make it higher quality? How can I, get care gaps solved quickly? So can you talk a little bit, because you've seen both systems at play. We're at Mayo's and now you in Malaysia. So
Yeah.
talk a little bit about the differences in workflow and why that clinical documentation and that data is so important.
I've not worked in the United States for over 20 years now. So it's very
It hasn't
much out
changed
of
much,
date.
by the way.
I'm sure that's not good. But how it's changed now here in the last 1 year is tremendous. We are a cardiac hospital, so most of our patients are in the 50 to 60 years of age group. So they have a lot of kids that may or may not be staying with them, but all of which want to know how dad or mom is. And what I found from our patient care app, which we call IJN Care, is that it's downloaded not only by the patient, but all their kids as well. And whenever I see my patients in the clinic and their kids are there as well, they remark on how easy it is to follow up on what's happening with mom and dad because of the app. So we find that to be quite an eye opener. That's not what I expected when we rolled it out, but it's something that we will move with. Of course, there are challenges. There are challenges with patient privacy. There are challenges with making sure that the data is secure, not hacked into. All of this remain to be challenges that are ahead of us. But we do realize that this is not something we can backtrack. You do bring up that most of medical records come in as a result of getting billing accurate as well. And this is something that we have our task put out to us as well. Because as we digitize, small mistakes in what we do become very large when it comes to the billing process as well. So the group has to include all of those people as well. So it becomes a very holistic organization-wide effort. But we soldier on.
Well, interestingly, you bring that up because that's a collaboration. And one of the things that you all have started to implement there at IGN is this multidisciplinary care plan. Everybody in their role gets to see a patient's care journey from start to finish.
Correct.
So that's one thing that really hasn't taken off a lot here in the States. So can you talk a little bit about that and how that's helped?
In a way, our lessons for that comes from the United States. Comes from I mentioned Mayo earlier. Mayo Clinic has, if you notice the logo of the Mayo Clinic has those three shields, and those three shields are meant to represent different specialities and how all those specialities must come together in the treatment of patients. The Mayo system, which I trained at, have their doctors um, receive a salary. They are not fee for service.
Mhm.
So therefore, if you were a patient at the Mayo Clinic, no matter how many doctors you saw for one procedure, you'd get the same bill. And that's the principle of collaborative care. And that's exactly what we try and push forward in IJN as well. It comes from the United States, strangely enough. It's collaborative care that we make sure that a patient coming through our doors, if they need to see many physicians to get them better, that's exactly what we do. And the medical record has to reflect this. So a collaborative care plan is exactly part of what we do. We document who sees them, but multidisciplinary meetings as to how a patient is doing and what we need to do and how to get it better is very much part of how we provide patient care in the
And
National Heart Institute.
and I'm kind of I'm interested in how the data, now that you've gone very much on the electronic side of documentation, so you've got a lot of data that can be shared. Has that actually helped that collaboration?
Oh, absolutely. The thing about this is we talked about AI earlier. Yeah.
Hmm.
We talked about the risk stratification that I've been doing for the last 30 years.
Hmm.
Now we've moved that to an AI algorithm. So formally, we did a PassNet risk stratification that looked at 8 risk factors. We moved that to Euroscore, which looked at about 15 risk factors. Euroscore 2, which looked at about 20 plus. Now IJN risk stratification engine, which is uses an AI algorithm, AI black box based on random forest, looks at 107 risk factors. So we have tested this and we find that the goodness of fit of the prediction model is really good. It's about 0.88, which is well, we're very proud of. It's still being piloted. We haven't quite certified it as good to go, but it's something that we are very pleased with, and we hope to roll out. At the moment, AI applications in the National Heart Institute is this. There's one more in imaging that we are working on, but nowhere near what some hospitals are doing. Recently, I visited a hospital in Indonesia which was doing an ambient listening model and analyzing that, and that was remarkable. They've got that working real time. I think that is the future. It won't be long before we see that in many applications. It's just too powerful.
It really is, and we have a lot of that adoption going on in the United States as well regarding ambient listening and AI manipulation of the notes and getting that into medical records. The issue's been trying to get that into data, real data that you can share.
Yeah.
But it seems like, talk a little bit about what your direction's going to be for AI. Where would you like AI to go next at IJN?
I would like to implement ambient listening. I would like to implement that to feed our databases as well. But there is a worry about its accuracy. There is a worry about autonomy being granted to an AI. I think the easiest way of looking at this is just like is AI a medical student? Is it a houseman? Is it a first year registrar? Is it a specialist? I have no doubt that in the future it will reach those upper echelons. But at the moment, I think it's hardly a medical student. So we've got to have the guardrails on while it gets clever. And that it will get clever is without a doubt. But for now, the guardrails need to be there. So, how I would implement AI in IJN, unfortunately, we are a third world country. There is a limited budget to go on this, and at the moment, it's more bleeding edge than cutting edge. So, I wait for a while. I follow it with great interest, but I'd be reluctant to tell our board that now is the time to invest in these solutions. It's a lot of calculation that needs to be done. For all of these AI servers, they cost the earth. The data transfer, you need to be able to make sure your entire hospital is able to push data at very high speeds in order that it doesn't slow down workflow in your hospital. You got to think about all of that. I don't think we solved those yet. We can. I mean, if you look at the DeepSeek in China and how they've actually made the processing overhead much less. I think this is the way that the industry will be going as the demands get more.
No, I agree. It's now they're throwing as far as healthcare is concerned, they're throwing AI just about to everything and every task. They're trying to apply it to every
Correct. Yeah.
aspect of medical care. And I find that
Yeah.
interesting and a little scary because,
Agreed. How would you consent to that as a patient as well? I do not know. I mean, that's something that we struggle with as well.
well, and there's also the responsibility of the AI solution itself. So does the AI make a decision that the clinician disagrees with or agrees with? Who
Yeah.
takes control of that? Who is responsible for that? There's a lot of things to be worked out as that,
Correct.
as you say, gets up the ladder at the higher echelons of medical
Yeah.
training.
Yeah.
Well, we're kind of coming down to the end of our time.
Yeah.
I ask this question of everyone that I interview
Okay.
for the podcast is if you had a magic wand and you could wave it and change one thing about healthcare IT, what would it be?
I changed the cost. I make it accessible to everyone.
Very
Unfortunately,
good.
not true. I mean, our pen and paper costs nothing, hardly anything. But that didn't do very much. Our computers, to maintain them, to run them, to connect them, it's a tremendous difference. I think Magic Wand take cost out of the equation. Unfortunately, Magic Wand doesn't exist, and what we instead have to do is justify that cost.
Absolutely.
ROI, however, difficult for us to argue, particularly when you're talking to board and you're talking to management. But there are a lot of bottom lines here. The
Eh,
bottom line is not only financial; it's in patient empowerment, it's in better care, it's in utilizing that data for the greater good. There's so many bottom lines here. So I think that's our task to management. Magic Wands, number two, is probably that people have the realization that if they do not do this and do not do this now, they'll be left behind very, very quickly.
What a great answer. I love your answer. If someone wants to get a hold of you and talk more about what you've done at IJN, how would they do that?
I'm on LinkedIn, Alwi Yunus, ALWIYUNUS. That would be the easiest way.
Very, very good. Dr. Alway, thank you so much for being on our podcast today.
Thanks. It's been fun.
That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys or myself at MedicompDoc, or check out the show notes for links. See you next time.